thank you, those of you who are able to participate. I'm going to be talking about using assistive technology to achieve better outcomes while reducing long-term care costs. And I'm going to give a little bit of background, and not spend a whole lot of time on a few kind of foundational pieces for folks who aren't maybe from the U.S. kind of understand what's happening here, and what assistive technology is and how it's viewed in the U.S. But I'll start off with just a little bit about me. I'm Dr. Jay Bulot. I'm the Chief Gerontologist and Vice President for State Markets at WellSky, which is a technology corporation, and we work primarily in the area of aging and disability services, and provide software for case management, care coordination. My bachelor's degree is in gerontology with minor in computer science, master's in nutrition and program evaluation, and my PhD is in gerontology with an emphasis in research method statistics. And roughly about 20 years ago, I first started working in the area of technology and aging while working on my dissertation and looking at how healthcare information was used and accessed by older adults back in the, I guess, late 90s, early 2000s. Tenured professor, department head of the Department of Gerontology, Sociology, and Political Science. Served sometime as a dean at the University of Louisiana, and then I've spent approximately 10 years in state government here in the States as state director for aging and disability services in the state of Louisiana and in the state of Georgia. And then I've done consulting. I led an LTSS practice nationally, working with primarily state healthcare agencies. I'm also an adjunct professor at the University of Massachusetts, Boston, and I've represented kind of all the states at a national level and different advocacy organizations. So a little bit about me. Aging in America, and this for a lot of you who have kind of a social background in aging and gerontology, should not come as a surprise. We've been seeing our population consistently aging, and now we're at a point where approximately 10,000 Americans are turning 65 every day, who are qualifying for some of our kind of universally available healthcare and services, primarily through the Medicaid population. Like other parts of the world, we see rapid aging. In the next 10 years or so, approximately 1 in 5 Americans will be over the age of 65. And as we've experienced for the last 50 years, 65 years or so, that large number of individuals as they move through society has changed it from the very first point in time in which they entered the school systems, and continue to change our society here in the expectations as they grow older on how, where, and when they receive their healthcare and long-term care services. So we're seeing that really starting to impact here, and in the way we've traditionally delivered services and to older adults, and what and how we're having to adapt to meet the needs for them going forward. And obviously the baby boom generation, as well as older adults who aren't quite there yet, technology has been a part of their life for the greater part of 20, 30, even 40 years in some cases. So there's a recognition that technology can and should, in their perspectives, play a part in how they age and stay independent. You'll hear me use the term assistive technology throughout this presentation, and I'll talk a little bit about what that means, but it's important to understand why I'm even giving this presentation. So 1 in 5 Americans are going to be over the age of 65 and by 2030. Today in the US, 1 in 5 Americans have some form of disability. So what does that mean in real numbers? That's about 54 million people in the state and across the United States have at least one disability that affects their ability to see, hear, communicate, reason, walk, or perform basic, what we call ADLs or IADLs, basic life functions. I'm a gerontologist, so a lot of this presentation will talk about older adults, although, the assistive technology I talk about will benefit people of all ages. So what does that mean for the scope of older adults? That's 8.5 million seniors require some form of assistance. 80% are over the age 65 living at least one chronic disease. Every 69 seconds, someone in America developed Alzheimer's, which affects a large portion of their ability to live independently on their own. The costs are astronomical here in the United States. My goodness, neighbors' kids. And one of the biggest drivers of our long-term care costs here is institutional care. And then, kind of the indirect burden is the loss to the economy on family caregivers and their ability or inability to continue to work. And then, as other parts of the world are experiencing, we have a pretty significant shortage in adequately trained healthcare providers, from nurses to doctors who have training in geriatrics and aging, to understaffing within nursing homes. We're experiencing that now with the pandemic and our inability to provide proper care because losing one or two staff persons out due to COVID is essentially, greatly reducing our ability to continue to provide care because we were already at kind of the minimum legally allowed staffing for most of our nursing facilities. So what is assistive technology? And so we have lots of different people will talk about the definition around assistive technology. In the United States, we have several pieces of legislation that helps us define what assistive technology is, and I'll use AT as an abbreviation going forward. But it's essentially any piece, any item, piece of equipment, software, or product or system that is used to increase, maintain, or improve the functional capabilities of people with disabilities. Now, we don't, outside of that broad definition, there's no other, list that says this is assistive technology, because we all see technology and devices differently. But you'll hear the term used, later on around person-centered. It's all about the individual and what that person needs in order to remain independent and able to live on their own. So this is what assistive technology is. It's devices that increase the legibility of small print. It is the robotic vacuum cleaners. It is the adaptive phones that provide increased ability to see, to navigate, to call, to hear. It is the smart cars that we're seeing more and more with the ability to self-navigate over short periods of time, predict accidents before they happen to assist an individual. It's the smart watches, it's smart homes, it's smart glasses, it's hearing aids, and it's eating devices, it's our cell phones. And that is what, when we hear it's technology, outside of it being what it is, it's what a lot of people think about. It's technology, it needs batteries, but it doesn't have to be complex technology that requires batteries and circuits and, advanced degrees in order to operate. Assistive technology, when we talk about, being able to remain at home and in the community, is sometimes really basic changes that happen that we either do to ourselves or that we do to the environment in which we interact in, and that makes it more usable for us. So you can see here some examples of low-tech assistive devices. A little piece of plastic that helps you hold onto a pencil or a paintbrush. It's an adaptation to an extension cord that allows us to plug in and unplug. It's a handle added to a round doorknob that allows us to open a door when we no longer have the dexterity within our hands. It's a shoehorn that many of us have used for the last 30 years. It's the chairs, it's the plates, it's really basic stuff that, again, is really important for individuals as they age. So it's as low tech as a grab bar, as a shower seat, as a pill dispenser, or as high tech as home automation, fully automated home automation that can be controlled from a laptop, a tablet, or a cell phone. And then I share when I was even when I teach classes now with my students, the most widely accepted assistive device is the big screen TV with the surround sound speakers. And I share that story both from a personal perspective, but also with family members as they age and how they've adapted to a decline in their vision and a decline in their hearing. And it's also seen by many as a status symbol. How big is your TV? What type of speakers? Surround sound. I personally, when I was starting to lose my ability to see, was considering buying all new living room furniture so I could sit closer to the TV in order to view it, not realizing that my problem wasn't that I wasn't sitting close enough, but it was the TV was a little small cathode ray TV, and it was just too small for my ability to see. So I saved $3,000 on new living room furniture by spending $700 on a TV that I could physically see. And some of you may recognize the Maxwell blown away dude. But you know, assistive technology doesn't always have to have a stigma attached to it, right? So we see somebody using a wheelchair, we see somebody using a walker, there's some stigma attached to it. We see somebody using a magnifying glass, there's stigmas attached to it. Those stigmas aren't because it's technology, it's how we've framed the use of technology. Whereas when we create elegant solutions like a large screen TV, high definition, or we create a cell phone that has built-in functionality that's adapted to the individual's needs, you know, it's something that we see value in. And I think as we talk about the use of technology, especially in the field of long-term care, aging, disability services, it's important to recognize that it doesn't always have to be this, you know, very, you know, I'm not going to say poorly designed, but a piece of technology that wasn't designed to benefit a large number of individuals. Whereas good universal design tends to be good for people with disabilities, but it's also good for people like you and I who are living independently. It just all of a sudden this is actually easier for us to use than it was before. Um, so I want to get into, you know, so and again, this wasn't a session on the types of assistive technology. There's all types, and it's dependent upon the individuals. Um, it was about how assistive technology can be used to, you know, improve outcomes and lower costs within long-term care. And I'm using the U.S. as an example because that's the, you know, the healthcare system in which I primarily work. But the costs are there, whether it's borne by the individual, whether it's borne from the health system. You know, there is a cost to providing long-term care. And in the U.S., our Medicaid system, which is our quasi-universal health care for low-income individuals and people with disabilities, is the primary payer for long-term care in our country. 55 billion in 2015, and that number is increasing year over year over year. When we talk about institutional long-term care, 6 in 10 residents in a nursing home, Medicaid is the primary payer, which usually means that they're going to be there for the rest of their lives. Whether I go in at 35 because I have quadriplegia, or whether I go in at 75 because I had a stroke and I'm no longer able to take care of myself, for the remainder of my life, the federal and state governments are going to pay for my long-term care. And then, as you can see, the LTSS kind of globally, Medicaid pays for the majority of benefits for older adults. So here in other parts of the world, that institutional level of care is the most costly setting of care. It's 24-hour staffing at minimum standards. It is having a nurse on staff all the time. It is having the room, the board, the housing, the healthcare, all being provided in that one location at a relatively expensive cost. And I want to share some kind of real world examples, but within Medicaid, the average here in the U.S. for a long-term care bed, and that's kind of if I have to go to long-term care, I want to live. I don't have to share my room with anybody. So the average cost for a single bed room, is roughly about $100,000 a year. Now that varies by states, obviously, right? So in some of our states, the average cost is 120, 130 thousand US dollars per year, and some of our other parts of the country where labor is a little bit less expensive, it may be closer to $89,000 a year for a single person long-term care bed. So I shared with you earlier that I was a state director in Georgia. I wanted to keep track of my time, and I administered both Medicaid programs for community dwelling older adults, and I also coordinated programs that helped individuals if they needed long-term care access institutional level of care. Roughly around 2007, 2008, we saw the widespread adoption of a program that was meant to help individuals transition out of an institution who preferred the community as a way to receive their long-term care cost or long-term care. So in the U.S., that was called the Money Follows the Person program, and my agency was responsible for standing up that program and assisting older adults and people with disabilities to move out of an institution when they've been there for, at one point in time, at least 3 months, and then we reduce the requirements going forward. But these were individuals who this was their setting in which they were receiving their long-term care for the foreseeable future, for as long as they happened to live. These were individuals who had IDDD. These were individuals who are adults with disabilities who weren't older or elderly, but they were people under the age of 60 or 65, depending upon the state that they were in, who qualified for Medicaid, and they were living in a nursing home as well. And then it was obviously the older adults who, when this program began, they tended to be roughly 80 to 90% of the beds were filled by older adults. And this is a real world example from whenever I was the state director, and we started looking at the cost of providing total health care to these individuals within an institution and what the total cost was as we transitioned them into the community. So it was the first year cost prior to transition, and then what was the total cost of healthcare, inclusive of the nursing facility bed, the room, the board, all the different services that were provided, as well as the total universe of healthcare costs that these individuals had. And you can see for individuals with intellectual and developmental disabilities, this is this number right here is the per member, per Medicaid recipient per month payment. And we saw a small amount of savings when we moved somebody from an institution who had IDDD to a community-based setting. So the same level of care, same types of services, but they were being delivered in a person's home or in a community-based setting within where that person lived. But the numbers here weren't necessarily statistically significant, the difference between institutional care and community-based care for people with IDDD. We started seeing the bigger numbers on our transitions for people with disabilities. And prior to the transition of that individual from living in a nursing facility to living in a community, we saw the average expenditures for that class of individuals at roughly $5,200 per month per person that who was an adult with a disability living in a nursing home. When we transitioned them out to the community, that first year total healthcare cost within the community was closer to an average of $3,500, almost $4,000 per month. So you can see a pretty significant. This is actually a statistically significant difference here in cost savings. Most of the individuals who transitioned out remained out. This data stopped at, they followed them after 3 years, but most of them stayed out for multiple years, and very few of them actually went back in. And then we see for older adults, and these are individuals who went in again when they were probably 60, 65, somewhere around there. And our average PMPM per member per month payment for their total health care was approximately $3,600 per month. And then after we transitioned them into the community, that number dropped significantly. $2,200 on average was the amount of money being spent to provide the supports to allow them to remain in the home, in the community, as well as any associated healthcare expenditures that person had over that entire year. So you can see clearly the cost differential between what it costs to provide institutional care, to have all the needs being met within an institutional setting, to the savings that's associated with providing all the same level of care to that person, but in a community-based setting. So, pretty significant cost savings. And this ties back into, and we'll get into it in a little bit, to the use of assistive technology, because invariably, when we looked at what was necessary to transition individuals out of a long-term care setting, technology and assistive technology and adaptive technology were all parts of the equation that we were looking at that we could bring to play in order to help that individual get out of the institution and back into the community. For those of you who are trying to do the math on what that PMPM, I figured I'd just throw it up there for you. Annual IDDD cost in Georgia was about $101,000 for an institution. Our annual, and we call this waivers, alternatives to institutional care, was about $62,000 for people with disabilities. And then on the aging side, institutional cost was about $43,000, and our average waiver costs, that again, the total savings was about $16,000 per year. So for each group, upwards of $15,000 per year savings by just changing the setting in which they receive care. And then obviously, most individuals want to remain at home in the community. They want to age in place. Levels of satisfaction were dramatically different from prior to institutionalization to deinstitutionalization by moving them back into the community. So this is based on the national program, Money Follows the Person. What we found was, just a tremendous shift in how and where people were receiving long-term care. So back about 20 years ago, over half of our funding that was available for what we call here LTSS, long-term service supports, which is inclusive of nursing facility as well as community-based care, was spent on SNFs and ICFMRs. Now fast forward to where we are today, and about half of the population is receiving their LTSS in the community. So many individuals are there. It's much less costly, but our institutional expenditures have remained relatively static. And a lot of that's due to the population growth that we talked about earlier. But what was really incredible is what we were able to accomplish as far as serving more people with the same amount of money. And this is just a two-state example. So Georgia was a state that I was responsible for. Much lower institutional costs than in Washington due to various factors. So in Washington, for what it costs for us to serve one person in a nursing facility, for the same amount of dollars to serve that one person in an institutional setting, we were able to provide the same level of services to 7 individuals within the community. So for the cost of one individual for a nursing facility, the same dollar amount could keep 7 people in the community. In Georgia, we didn't quite experience the same radical savings or the ability to serve more people, but for what it cost us to serve one individual in an institution, we were then able to take the money saved and then serve 3 individuals in the community for the same cost as institutional care, which again, I think says a whole lot, especially when we start looking at the quality of life that people had from an institution to the nursing facility. And this is some more data from our Georgia Money Follows the Person program. And you can see overall life satisfaction, to satisfaction with healthcare, to satisfaction with where they live at, reduced depression, and then reduced barriers to community integration. Time after time, we see the trending in the right direction. So your light blue column is prior to, this is their quality of life in a nursing facility. Then when we got them out of the nursing facility, you see the large increase or the decrease when it was appropriate for fewer symptoms of depression and more ability to be involved within the community. In Georgia, we tracked this for an additional 3 years, and the same trending held true year over year over year. Here's another example. This is from the national study, and you can see the overall life satisfaction again, pre-transition, post 1 year transition, in 2 years, and again the trending is all in a positive direction with where you want to see it, where people were much more satisfied with the community-based care versus institutional care. One more measure from the national study that was done, quality of care by length of time in the community. Again, we maxed out at about 85%, but from that first year to that second year, again, dramatic increases. And then what I think is interesting is the unmet needs for assistance with ADLs. These were folks who were living in institutions who 18% of them, their needs still weren't being met, even though in theory they had 24-hour care, until the go fast forward to that first year transition, to that second year transition, their needs were much more being able to be met in the community than they were even in an institution. Now, the medical care didn't change a whole lot, access to medical care, which was good because in theory they had access to 24-hour medical care within an institution. Little change from that institutional level of care to community and the ability to access healthcare. I don't know that this will play just because I wasn't able to sync my my video with the way I was able to log in. But this is an example from Georgia of one example on how assistive technology is beneficial. And I'll just share Lisa's story with you. You can Google Lisa and Tools for Life Georgia on YouTube. But one of the first instances in which we recognized the ability for assistive technology to play a part in helping individuals move out of institutions was this individual right here, Lisa. And she was in an auto accident and had went into a nursing facility in her early 50s. And she'd been there for several years. She was paralyzed from the neck down. So she was completely dependent upon the care staff within the nursing facility to meet her needs, to help her get up, to change the channel, turn on the lights, help her in and out of bed. For her entire ADLs and IADLs, she was completely dependent. But she reached out to our Money Follows the Person program in Georgia and expressed a desire to move out. I don't want to live here anymore. Can you help me get out of the nursing facility? And so we went out. We talked with her. We talked to family that was available. We leveraged what we have in the States is Centers for Independent Living, which help individuals with disabilities kind of navigate the arena of available services to help people remain in the community. So we reached out to our sister agencies and our partners in the community to say, you know, can we help Lisa move out of an institution? Can we allow her to have the quality of life that she desires in her home? And we did. And it was really impressive with the technology that was available. And this was going back 4 years ago now. We were able to completely automate her home. She had access to control her blinds. She was able to open and close her blinds when she wanted to. She could verbally command the television to turn off and on and change channels. She didn't have to press a button. She was able to open and close her doors as she wished. She had the privacy that she wanted. She was able to do everything that she was dependent upon an institution to provide and staff. We were able to bring in technology that she had complete control over to be able to automate her life so she could live independently in her home in the way that she wished she could. And you know, so as a result, she's been out for several years now. Every year that she has been out living independently using assistive technology is a cost savings to the state of $80,000-$90,000 a year. And you know, the assistive technology purchases were a one-time expense that is still benefiting her today. And this is a real world example of how assistive technology is being used. And I'll give you the case study where this came from. But you know, for what it costs for us, and this is kind of the equivalent in one of our what's called the area agencies on aging. These are access points for older adults to access resources within the community to help them remain at home and in the community. We were able to buy 14 transfer benches at a one-time cost of $840. So 14 people at $60. Now, the need for something like this would be getting in and out of bed, transferring from your bed to a wheelchair. And to do that through the traditional methods is to have a home health aide come into your home, usually once a day, sometimes twice a day, and doing that for you, physically helping you get out of bed and transferring you into a wheelchair. So the cost here in the state of Georgia to do that at the prevailing Medicaid rate for a personal care aide to come into your home for 14 people is approximately $207,000 a day. We were able to provide a piece of low-tech assistive technology at the cost of $840 total to meet that same need. You see the next one is the 24 tub safety bars. And again, able to do that for $720 one-time expense. Now, the need that translates into is somebody who needed assistance bathing. So how would we meet that need? That would be somebody coming in. Usually it's a lot cheaper because we don't believe in, and I'm being facetious here, so, and very much cynical, we don't believe in you needing a bath every day. So we will probably send somebody out there once a week, maybe twice a week, to give you a bath if that's what you need assistance with. And the cost to deliver that service here within Georgia is about $50,000 a year for 24 people to get one bath a week. And because the need was just somebody needed help getting into and out of a bathroom, we were able to meet the needs at 720. Bath chairs, kind of the same thing. Alert system, somebody was living independently, but they still need to have somebody check in on them. We were able to purchase 21 of those at $70. This is the non-contract emergency responses, and for $1,400 to have one person check in on that person once a day. For 21 people, that'd be about $107,000 a year. And then what I think is neat is the dining kits. One of the biggest demands we have in Georgia, and one of our largest wait lists, is for supplemental meals or our home delivered meals program. And for 15 people to receive 3 meals a day every day of the week, that would be about $121,000 a year. Now, the person may have the ability to cook the meal, but they may have some limitations that allow them, they can't open a can anymore because of arthritis. They can't work a knife anymore because they don't have the arm and wrist strength to be able to work a knife. The pots are too heavy. They can't fill up a pot and cook. So by providing what we call the dining ADL kits, this is your activities daily living, the things that allow you to use a fork and use a plate. For 15 people is approximately $1,600, and for the home delivered meals, $121,000. So a real world example of how AT can save money and then allow people to be much more independent upon their own is, within 1 year, 7,000 for the technology to serve all these individuals. If they were being delivered in our traditional modality of a person going into the home and assisting that person when it may not be what they want to do it themselves, is almost 800,000. So you can see that there's lots of opportunities here. And you see at the top, when somebody came to my office looking for services, once we enrolled them, they tended to have an annual a length of stay of approximately 3 to 5 years that we were paying for services for that individual. And at which point, they either, they may have passed away, which was for us that's a win if somebody was able to live and then die in their home, or it got to the point where their needs could no longer be met with the levels of funding that were available. So I want to describe a little bit about the program that I just referenced, the cost savings, and how that looked and how that worked. So I mentioned that we had wait lists for meals, but in Georgia, most of our services for community dwelling older adults who weren't eligible for Medicaid had wait lists for them. In order to qualify to get on a wait list, you had to meet our nursing facility level of care, which meant that you had significant deficits within your ADLs and IADLs. So as somebody called in our Aging and Disability Resource Center looking for services, we would do an assessment of that individual. So what do you ask? What do you need? We'll do a needs assessment that looks at both physical and social needs and where deficits exist. And as our counselors identified unmet needs that could potentially be met by technology, we would highlight and keep those pieces and talk to those individuals about what it sounds like they need, and do we think we have some assistive technology that could potentially be of use to that person. We would invite that person or their family to our assistive technology labs that we had in every one of our regions, and allow them to look at the assistive technology that was available, allow them to the extent that they could, see if that met their needs, and we would be very upfront with that individual to tell them that, if you think this will meet your needs, we will buy that piece of assistive technology for you. And, we won't put you on a wait list for services, because for some individuals, a wait list could be 6 months, it could be 9 months, it could be a year, 2 years, depending upon the severity of the people who asked for that service before you did. When somebody said, yes, I'd like to try the assistive technology, we didn't just wash our hands of those individuals. We kept following up with those people, and we encouraged them, if you have a change in status, if you get sicker, you get more frail, you have more disability, let us know, because we will reassess and see if we need to do something else, if you might qualify for service immediately. But invariably, most individuals chose to try out this assistive technology. And you can see on the right here, kind of did you even know this existed? And most individuals who came to our, AT lab as a recommendation to try out some technology didn't even know assistive technology existed. And this is older adults. And then when we did a follow-up is how satisfied you were with the equipment that we gave you. Most of the individuals were primarily satisfied. And so, in this time period, we gave 144 people assistive technology equipment to help them with their ADLs and IADLs. And again, kind of we pull pages and pages of comments, but it helped people remain independent. It helped them bathe. It helped them eat. It helped them eat. It helped them, remain in their homes and in their communities. But by purchasing that AT at one point in time, so for every year, that's money that's available to somebody who couldn't benefit from assistive technology when we had to send a person out. And you'll hear the term later. I stole a tagline from Geico: technology when you want it, people when you don't. And it's something that I feel strongly about, that, we don't force assistive technology on people. They have to choose it. It's a person's choice. And if a person's not at all comfortable with technology, then you don't give it to them. That's when if they want people, we have people. But if you want technology, we make sure technology is available now. One of the early barriers we found when we first started this initiative here in Georgia around assistive technology is that a large lack of understanding on what actually assistive technology was. I shared those slides earlier about the HighTech, LowTech. Most people, when they think about assistive technology, their mind goes to these robots or computers, and I don't want to have to deal with any of that kind of stuff. So we had a barrier of both educating the public about what assistive technology was, but also our network of regional care coordinators and providers and counselors, because they too had the same misperceptions about what assistive technology was. So we went through a concerted effort. We started buying small AT lab boxes that we kind of put on a roadshow. We introduced people to them. We showed them that there was nothing to be afraid of. When we talk about assistive technology, this is what we're talking about. And then on the policy side, as a state director, we also modified our policy to allow the purchase of assistive technology within any program that a person might qualify for. So that was one fewer barrier. So once our professionals working within our network were familiar with it, we had to figure out a way to get it available to the public, to older adults to kind of experience. And that's where the public-facing AT labs developed. And our pilot was in South Georgia. And it still today is a kind of a best practice where it is open to the public every day. We will help you understand it. You can try it all out. We have bathtub lifts. We have, transfer chairs. We have a kitchen set up. We have a bathroom set up, a living room, a bedroom, and you can see what needs you have and would this meet your need. If somebody has the resources and they want to buy it, we put them in contact with the entity that can, provide that to them. If it's somebody who they don't have the resources, but we can pay for it and meet their needs, and we'd be able to do that as well. But there's still that awareness that needs to happen on, what is assistive technology and what does it mean for me? This is one picture from one of our AT labs here, and you can see there's at the bottom there's a living room with a front door, kind of the ring bell, door told them to lift chairs. There's a bedroom. There's a kitchen set up. At the bottom right is a bathroom with all the AT that's available within a bathroom setting, and then there's a kitchen to the bottom left with all the AT that was available for a person in the kitchen. And some of this was high-tech assistive technology. Most of it was really low-tech, inexpensive things that would help an individual just remain independent just a little bit longer. And here's my technology when you want it, people when you don't. Assistive technology, we've seen it dramatically impact people's ability to remain at home in the community for as long as possible. But again, we we don't encourage, we don't support um, the forcing of assistive technology on a person unless it's something, a decision that they make themselves. So we use and we encourage everybody, as you look at assistive technology and how it can benefit, your aging population, people with disabilities, that you take a person-centered approach to it, and we call it person-centered assistive technology counseling, where you understand what that person's experience has been with technology. And this could be technology as simple as computers and a cell phone, or within a home that that is familiar to them. What's been their experience? What is their interest? Um, and then start from there to introduce different concepts to that individual. Does this play to their strength? Is this a weakness for an individual? My grandmother, is somebody who's, the high extent of her technology use was a remote controlled television and a telephone that was a landline. And um, she has now had the flip phone because it is the most similar to what she experienced with the with the telephone. Is buttons, you dial them, you talk, you hold it like you do a regular phone. Um, we've introduced the concept of a current modern cell phone, right? It's a flat screen and looks like a tablet. Um, but for her, that would not work. She's 89 years old. Um, the dexterity isn't quite there for her. The way in which she interacts with technology does not translate really well into her use of more modern technology. So that's something that has to be considered. What is that person's ability to even understand the use of technology? So we see a great impact for people with dementia and how assistive technology can be useful. But it may be high tech, but more than likely it's the lower tech technology that's a very common concept for them, but it's just maybe a little twist on how they might grab something. Instead of it being a small spoon, it's a big spoon. We see assistive technology working in people with dementia by changing the color of a plate versus the color of a table. Um, we don't think about that as assistive technology and adaptive devices, but it is exactly meant for that, to help food be more visible for the person as their vision declines and their cognition declines. Um, and then the other question that we always ask, and this kind of feeds into the cost and what might be, something that could be afforded by either the individual or the entity, is how useful is it across settings? So does this only work in the home, or does it also work whenever you leave the home? And then does the device adapt? Does the technology adapt, or does it still meet the needs as a person's symptoms or condition worsens over time? Or is it only good today, and in 6 months from now, it's not going to be effective? So those are some pieces that as we talked with individuals about assistive technology, that to help them understand, and to help the counselors who work with them understand, um, what do we need to do to help that person? What do we need to know to help that person make the best decisions for them? So, I'll leave it with I have a little bit of time for questions with the quote from an IBM training manual in 1991, which I think encompasses technology of all types, but especially as we get older. For people without disabilities, technology makes things much easier, right? But for people with disabilities, technology makes things possible, and that's from, again, the most high tech to the most low tech. It's good for us who don't have any disabilities, but for individuals who do, it makes the difference between being completely independent to being completely dependent upon an individual. And that's my contact information.